Hello. All right, in this video, we are going to discuss common tests, procedures, lines, and tubes that you will encounter in the medical setting. So we'll start with our learning outcomes. By the end of this video, you will be able to identify various tests, procedures, lines, and tubes, understand when and why they are used, explain why this information is important for a medical SLP, and the importance of other members of the medical team. All right, we are going to start with angiography. This is a test to look at blood flow, and it's used for circulation studies. It's frequently in the context of heart health. So a cardioangiogram is a study to look closely at the heart's blood vessels and chambers. Blood vessels don't show up clearly on regular x-rays, so they use this test to take a better look. Contrast is injected into the bloodstream, usually by way of a catheter that's placed through the femoral or axillary arteries. This isn't a test that involves speech-language pathologists, and it doesn't impact anyone's speech or swallowing, but it's important for us to know what it is so we can understand bed rest and mobility precautions if we are trying to work with this patient. After the procedure, patients sometimes have to be on flat bed rest for 2 to 6 hours after. So if you know that your patient has just returned from an angiogram, you're going to want to make sure that you're allowed to work with them. Obviously, a patient lying flat in bed isn't very conducive to a great speech therapy session, whether you're seeing them for swallowing or something speech related. So this might be somebody that you want to hold off until the afternoon or maybe even see the next day. All right, the next thing that we will look at is an arterial line, which you will hear called an ART line or an A line. You can see a picture of it on this slide. You will see this a lot in critical care and ICU settings for a couple of reasons. An A line measures invasive blood pressure directly and continuously. So it gives the healthcare providers a continuous look at the patient's blood pressure without them having to put a cuff on and take it that way. It's also a lot more accurate than taking blood pressure from a cuff. The other reason it's handy is that it can be used to draw blood. So this is key for someone who is in a critical condition. Patients in the ICU are sometimes getting blood draws on the hour or multiple times an hour. So instead of sticking the patient with a needle every single time, they can draw blood from the A line and use that for any and all blood tests that they want. The arterial line is usually located in the radial artery, but it can be placed in other spots depending on the patient and their needs. The biggest thing to know if a patient has an A line placed in their femoral artery is that they can't get out of bed or do any sort of hip flexion. Also, they're on bed rest for 6 hours after it's removed. If the A line is in the foot, the patient can't get out of bed. So like we just talked about for the angiogram, this is important to know if you're wanting to get the patient up and out of bed for a speech therapy session. I'll reiterate this probably a few more times, I'm sure, but always check in with the nurse before you work with the patient, especially if you're in the ICU. All right, one of the essential blood tests that you will encounter quite a bit in the medical setting is an arterial blood gas, or ABG. This is a test that measures acidity, or pH, oxygen, and carbon dioxide. So it's used to see how well the patient's lungs move oxygen into the blood and remove carbon dioxide. These numbers can indicate kidney or heart failure, so that's essential. They're going to want to catch that early on. An ABG is frequently used in critical care settings, especially for patients who are on a ventilator for breathing. The results from this test can guide decision-making about when and how to wean the patient from the ventilator, and it also helps them with decision-making about when to extubate. An ABG is usually retrieved by the respiratory therapist. They'll run the test and they get a little receipt back with the detailed results. You can see it, that's the picture on the bottom left-hand corner of the slide. So if you're ever a part of interdisciplinary rounds, this is something that you'll see and hear the doctors and nurses and respiratory therapists talk about pretty frequently. All right, so we talked about A lines and blood tests, but another essential line that you'll see in the hospital, sometimes even in outpatient and home health settings, depending on your patient and their needs, is an IV. An IV is inserted into the back of the hand, the forearm, or inside of the elbow. It's used to deliver fluids directly into the vein. So this can be actual fluids, something like saline for a restoration of fluid balance or quick hydration of tissues, or it can be medications, so something like morphine for pain or antibiotics. IVs can also be used for transfusions. So when someone is given a bag of blood from a donor, you'll see them attached to IV poles, like in this picture, if you're in the inpatient setting. So you'll see people walking around with them. Usually people can walk around with them pretty well if they're mobile, but you just have to be careful that the IV isn't plugged into the wall, and also that it's not getting tangled up with other lines or snagged by the bed. All right, a central venous catheter or a central line is another type of line. I don't think I mentioned it before, but catheter is just another name for a tube. All right, so this is similar to an IV line, but it's longer and it has a larger tube. It's placed in a large central vein in the neck, upper chest, or groin. This type of line has benefits because of its placements in a large vein. So to begin with this line, nurses can administer a large amount of fluids quickly. So this is helpful if someone is in shock or some other state of emergency. You can also use it to deliver IV medications over a longer period of time. So things like chemotherapy or antibiotics. Those are things that a peripheral IV, that one that we just talked about, can't really handle. This line is also less likely to come out of the vein. So you'll see it used with patients in the outpatient setting. They can receive their IV medications, but they can still be active and move around at home when they're not hooked up and actively getting their meds. A central line can be used short-term for hemodialysis for someone who's experiencing kidney failure. It's also sometimes used to give nutrition by way of TPN. TPN is total parenteral nutrition, and it's used to provide nutrition to people who can't use their GI tract. So instead of using the GI to process nutrition, it's just put directly into the vein. The last benefit of a central line is that it has a longer shelf life, so to speak, so it can remain intact for weeks or months, which is longer than a peripheral IV. All right, this is a PICC line, or a peripherally inserted central catheter. It's similar to the central line that we just talked about, except for the point of insertion. So this one is inserted into the arm and it delivers into the larger veins near the heart. Because of this, it has similar benefits to the central line. You will see a PICC line used to deliver IV medications over a longer period of time. So again, things like chemotherapy, antibiotics. And this is also frequently used for the TPN that we just talked about. And like a central line, it can remain intact for weeks to months. All right, a chest tube is a drainage system. So this has tubing attached. You might run into these a lot, especially if you're working with trauma patients. So you can see in the picture, but there's a hollow flexible tube. So that's inserted into the chest. It drains blood, fluid, or air into a container. You can see the container sitting, like that canister sitting down on the floor next to the bed. This is necessary to normalize pressure in the pleural space. So the person with the chest tube will usually get a few chest x-rays along the way. They'll get one after it's placed, just to make sure it's in the right spot. They'll probably get a chest x-ray again before it's removed, just to make sure that everything has been completely drained. And then afterwards to rule out pneumothorax, which is like a collapsed lung, but to make sure that their lung is fully re-expanded. It's important to be aware of a chest tube when you're working with someone. So you'll want to let the nurse know if you notice any kind of kinking in the tubing or connection issues. You'll also want to watch your own movements, how you're raising or lowering the head of bed. You don't want to accidentally pull on the tube or knock over the collection canister when you're kind of standing there right by it. Okay, we are going to move on to some tests that you might run into. So an EKG or an ECG is an electrocardiogram. This is a test that measures the electrical activity of the heart. So there are 5 leads attached, usually to a person's chest, but sometimes their limbs, and that person is hooked up to a machine. The technicians complete this test just right there at bedside. It gives them a printout with all of the necessary information. You don't really need to know how to interpret an EKG, but it does give you another piece of the puzzle when you're working with someone. For dysphagia patients, it's good to know if they have any cardiac restrictions to their diet. Otherwise, this is probably just a test that you will see technicians entering and leaving the room. So in that case, you'll just kind of want to figure out scheduling. So if you're both wanting to work with that person at the same time, this test doesn't take very long. So maybe they finish that EKG and then you come back 20 or 30 minutes later. Telemetry is extended cardiac monitoring. So if you work in a stroke center or with cardiac patients, they will likely be hooked up to telemetry. If you remember back in the first week, we talked about how telemetry can be a whole floor or whole unit in a hospital. It's similar to the EKG in that there are leads attached to the patient's chest. It's all hooked up to a little remote or a pack that just sticks like in their hospital gown pocket or just sits next to them in bed. The information from these monitors is readily available to the nurses and the doctors and to us. It'll be up on monitors out at the nurses station. And then it's also transmitted to a monitoring room or a telemetry room where they have a technician in there watching all of the monitors, and they just keep a really close eye. They'll call the nurses if they notice any activity that needs attention. The biggest thing for you to know about this is that sometimes you will hear the monitor beep or alert. Sometimes it means that the nurse needs to do something for the patient, like maybe one of their like their heart rate is too high or too low. It might also be something like a lead popped off of their chest, or maybe the battery died in the pack. So any alert, any beeping that you hear, you'll want to look into it before you continue on with your session. All right, another test that you might see being done at bedside is an EEG, or an electroencephalogram. With this test, electrodes are applied to the scalp and they're hooked up to a piece of equipment or a computer. It's used to measure the electrical activity of the brain. So just like with the other test, the technicians and the doctors receive immediate results on various measures of activity. So an EEG is commonly used for people with epilepsy, people who have brain tumors, people who have experienced brain injury or stroke. Okay, if you're working in the ICU, you might also run into an external ventricular drain, or an EVD. This is a temporary drain that is used to measure intracranial pressure, or ICP, drain excess cerebrospinal fluid from the ventricles, and relieve pressure. So this is something you need to be pretty cautious around. The drain needs to be adjusted when the patient changes position or moves in bed. So just say you want to sit someone up in bed, but they have an EVD. You need to talk to the nurse, because the nurse will come in to close the drain. They'll reposition where it needs to be once you elevate the head of the bed. Same process when you're done with the session and the patient wants to lay back down. The nurse would have to come in, close the drain again, reposition everything how it's supposed to be. It's really important that the drain is in the correct position for it to get an accurate read of the ICP, and so it drains the CSF the way it's intended to. So this slide just has some pictures of it. The picture on the left shows what an EVD setup will look like at the patient's bedside. If you're working in the ICU, seeing this kind of setup with this amount of lines will eventually feel normal. You just have to be really cautious when you're moving around so you're not bumping something or tangling any of the lines up. The image on the top right shows where the drain is placed and how it's connected to the pressure scale and the collection chamber. The image on the bottom right gives you kind of a better idea of how the drain needs to be leveled. So when I mentioned that the nurse would come in to close the drain and adjust its position, this is kind of what they're being careful to keep level. They'll usually have a yardstick or some other long stick to physically check their level to make sure that everything is aligned properly. Okay, another device that is used to remove excess cerebrospinal fluid is that's causing increased pressures in the brain is a shunt. So this is often used in patients who have hydrocephalus. It's the same-ish idea as an EVD, but this is a permanent solution. It's a flexible tube that's placed into the ventricles. The catheter then routes the CSF to another part of the body, so somewhere like the stomach, because it can be more easily absorbed there. People who have a shunt need to be monitored throughout their lifetime because sometimes adjustments need to be made. So if the shunt is over or under draining CSF, the person might experience symptoms. They would go to the doctor, and they would have to make adjustments to the shunt. All right, craniotomies and burr holes are other procedures you will encounter if you're working with the neuro crowd. These are techniques used in treatment for head injuries, more specifically subdural hematomas. A craniotomy is when a section of the skull is removed so the surgeon can access the hematoma. It also allows for time and space for any swelling to reduce. So usually a temporary bone flap is put in place of where the missing piece of the skull is. They'll store the piece of that skull in a freezer, or sometimes they'll actually even use a subcutaneous pocket in the abdominal wall, like inside the patient, um, until the patient is ready for it to be replaced. So that would be like when the swelling is reduced, and they can put their skull kind of back together essentially. If the patient does have a bone flap in place, you'll usually see signs up around the room, just kind of warning everyone that that's the case. And usually that person will have to wear a helmet if they're out of bed to protect that particular kind of softer spot on their head. Burr holes are small holes that are drilled into the skull to relieve pressure on the brain that's caused by fluid or blood buildup. A flexible tube is placed to drain the blood. It might be left there for a couple of days post-op until that area is completely drained. So that brings us right along to drains. A Jackson Pratt or a JP drain is a very common brand used for wound drainage. It's a closed suction medical device. So this prevents fluid buildup from disrupting wound healing or causing infection. So there's a tube inserted into the wound or burr hole area, like we just talked about. It's connected to a little bulb. The bulb collects the drainage and it's consistently emptied. Nursing will keep a close eye on the drainage. They'll usually record for the amount coming out of the wound and also the color or other characteristics, because they'll be monitoring close for infection. Once the site is clear, then they'll remove the drain. So just like with our other lines and equipment, it's good to know if someone has a JP drain, because you'll want to be aware of it in your surroundings. If you notice a poor connection or that it's catching on something, you'll want to notify the nurse. Depending on the site of the drain, they may need to lay flat or in a specific position. Again, this is something that the nurse would notify of you when you ask if you can work with the patient. So it's always essential to check in with them. All right, next up are rectal tubes. This is a flexible tube that's inserted into the rectum. It does exactly what you think it does. It removes stool. There's a bag on the other side that collects it all. Nursing staff will consistently monitor and empty this bag. Things that you need to know are that they usually don't have an airtight seal, so you might notice some uncomfortable smells in the room. They can also leak and easily pull out. Not like it happens all the time, but it's just something to be aware of if you're moving the patient out of bed or, again, moving the head of bed up or down. A urinary catheter is another pretty common thing you'll see in the medical setting. It's frequently called a Foley because that's the most common type that's used. This drains urine from the bladder and into a drainage bag. So same as with the rectal tube, the nursing staff will frequently monitor and empty the bag. Nursing, they're often frequently monitoring I's and O's is what they'll call them. So that's input and output. That just means that they're closely tracking how much fluid a person is taking in and how much urine that they are peeing out. So they'll also want to closely monitor the color to watch for any sort of UTI or infection. A Foley isn't meant to be long-term. They can actually cause a UTI, which is specifically called a CAUTI, or a catheter-acquired urinary tract infection, if it is due to the Foley. So this is a big issue in some hospitals. A lot of them try to take really good care if a catheter is placed. So they'll keep the site really clean, they'll empty the bag frequently, and then they'll remove this urinary catheter as soon as possible to just reduce those chances of a CAUTI. What you need to know is similar to the other things around the bed. Use caution when you're moving the head of bed up or down to make sure the tube isn't getting tangled or stuck anywhere. People can walk around with both rectal tubes and urinary catheters. So if you're moving someone maybe to the speech therapy room on acute rehab, that's fine. You would just need to hook their bags to their walker, their wheelchair, or you would just carry them along with you just to make sure that they're not getting stepped on or wheeled over. A straight catheter might also be used. This is something that's placed, the bladder is drained, and then it's immediately removed. So if someone's being straight cathed, you don't really have to be worried about moving it along anywhere, but it's sometimes good to know because that gives you insight to whether or not your patient is continent, or if they would need reminders, or if they would need the nurse to come in maybe during your session to empty their bladder. All right, we are nearing the end. Tube feeding. There are a lot of tubes and a lot of methods. You won't be expected to be the expert, but it is important that you have an idea of what tubes are out there and why a patient might get one over the other. Tube selection depends on a couple of things. Usually the first decider is short-term versus long-term. Most short-term methods are meant to stay there for no more than about 14 days. You'll definitely see exceptions to this. So maybe the team thinks that the person will be able to eat in 3 weeks. That's pretty close to 14 days. So a short-term option still makes more sense than surgically placing a long-term tube. The doctors and dietitians work closely together to make these decisions, but the SLP is often included in this conversation if the reason for needing a tube feed is because of dysphagia. The next part of the process is deciding where they can or where they want to feed. So each of these tubes is placed in a different spot. So depending on medical factors, the doctors, usually the gastroenterologist or the GI doctor, will decide which tube makes the most sense for that person. I will say that most often you will hear people say, and you'll see people write in their notes, PEG tube for any of those long-term options. So whether it's a G tube, a J tube, a GJ, almost everybody on the medical team just calls it a PEG tube. The GI doctor will usually be one, and the dietitian will usually be the providers that have a really thorough note, and they'll use all of the correct terminology. So just something to kind of note or something that you might see. Okay, so I'm not going to say a lot about these images, but I find them to be helpful when you're thinking about the different types of tubes. So these images come straight from our textbook. It's on page 257. It just shows you where the tube starts and where the tube ends. So on this image, you can see like the NG tube and you can see the duo tube. So again, they have same start place in the nasal passage, but different end places. So they're feeding kind of to different places. This next image shows you the NJ tube and the esophagostomy route. And here we have the G and the J tubes. So again, you don't have to be the expert on tubes, but I will say that our patients tend to ask us a lot of questions about them. So you can listen, you can answer what you can. You'll always encourage them to ask specific questions to the GI doctor and even to the dietitian. I think one of the most common concerns people ask us about is the long-termness of a G or a J or a PEG tube. No one can usually predict how long someone will need a feeding tube for. So a lot of people get kind of nervous about those long-term options. The placement of them does involve a pretty invasive surgery. So it is a risk, but sometimes it is what people need. So one thing I try to remind people about is that no tube is forever. So even if someone needs a PEG tube right after their stroke, let's say their swallow improves, they start eating, that tube can be removed. So usually GI doctors will want to wait until about like the 6-month mark. They won't want to remove it right away because that area needs to heal before it's operated on again. But even those long-term options, that doesn't mean forever. So it's nice to remind people that also like that tube doesn't even have to be used. So again, maybe their swallow improves, they can eat after a month. But the GI doctor says, well, it hasn't been long enough for us to remove it. They still don't have to feed it. Like they don't have to put tube feeding into it. They can just flush it. They can keep it clean and then continue to eat by mouth. So I think sometimes those are the questions that come to us, but you can give people that reassurance that they can do both. So we'll still work on swallowing, even if they have a feeding tube, as long as it's not otherwise contraindicated. I know you guys probably hit on this a little bit in your dysphagia class too, but we can talk about it more in class if you have other questions. All right, so let's take one final look at the learning outcomes. You should feel comfortable with all of these objectives now that you've reached the end of this video. Please feel free to email me questions, post on Yellow Dig, or ask in class if you want to talk about anything further. All right, thanks.